So, good afternoon, everyone. You are all very welcome this afternoon to our Sláintecare webinar. I am Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement, and I'm delighted you've joined us for today's webinar, the 11th Sláintecare Integration Fund webinar, part of our Learning Network event series. We are taking questions during the broadcast, so if asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The Q&A button is at the bottom of your screen, and if you type in a question, it will come straight into us. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is about providing right care in the right place at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Sláintecare integration funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. A key aspect of the Health Service Capacity Review of 2018 is the shift of care out of acute hospitals into the community and closer to a person's home where safely possible. Reducing our dependence on the current hospital-centric model of care and supporting capacity building in the community is key to realising the vision of Sláintecare. This afternoon, our focus is on enhanced community care. We're featuring presentations from 4 Sláintecare funded initiatives. But before we hear from the 4 projects that we've chosen for you today, we're going to talk to some of those who are leading out on delivering enhanced community care to hear what it is and why it is an important element of Sláintecare implementation. Let's hear from that panel now. So I'm delighted to welcome our first panel this afternoon. I'm joined by Rachel Kenna, the Chief Nursing Officer with the Department of Health, Pat Healy, the National Director of Community Strategy and Planning with HSE, and Dr. Orla O'Reilly, the National Clinical Advisor and Programme Group Lead for Chronic Disease, Clinical Design and Innovation. You're all very welcome and we're delighted to have you with us this afternoon. So Pat, maybe I'll begin with yourself. The theme of our session this afternoon is all about enhanced community care. Would you tell us what it is and how will it be achieved?
And thanks. Like what we're trying to achieve with the Enhanced Community Care Programme is to reorientate our service delivery from acute hospitals to the community, providing timely access to primary care, aligning it with general practice, and delivering services at home and in the community, which is what our patients and service users want and need. And obviously, in doing this, we will also take pressure off our very stretched acute hospital system and ensure more integrated care will be delivered locally. So community healthcare services in the future will be delivered through a network of 96 CHNs, as we call them, community healthcare networks. And these will provide the foundation and organizational structure to which integrated care can be provided locally at the appropriate level of complexity, with GPs, health and social care professionals and nursing leadership empowered at the local level to drive integrated care and supporting egress from the hospital system to the community in a smart and efficient way for the public.
Great. And I know from the 4 projects that we are showcasing this afternoon, they're all working according to that plan. We're hearing stories of move into the community, greater connection with GPs, and we're hearing of, fewer footfall into acute hospitals and people receiving care closer to home. So it's on the move and it is happening. Orla, can I come to you and talk to you about the aim of the Integrated Care Programme for Prevention and Management of Chronic Disease and the connections to the clinical programs and indeed to enhanced community care?
Sure, Gráinne, thanks. The Integrated Care Programme for Chronic Disease is one of the 3 elements in the Enhanced Community Care Programme. The other 2 are older persons and, as Pat described then, the community service CHNs. So it's just about the Integrated Care Programme for Chronic Disease. The aim of the programme is to provide end-to-end care for people with the chronic diseases of heart disease, diabetes, COPD and asthma, based in the community. And doing this by supporting the patient themselves with education and skills training for self-care, supporting their general practitioners with easy access to specialist services in the community and brought from the hospital into the community, and also linking very closely with the local hospital consultants and providing diagnostic services in the community. So in fact, it links the whole spectrum of care and provides as much as possible of it in the community.
And Orla, what will it mean for patients? I mean, you've described some of the shifts, but how will it feel from a patient perspective? What will be different?
Well, take community diagnostics as an example. A lot of people now who require maybe an echocardiography or a respiratory spirometry test would need to actually go to an outpatient service in the hospital and face a long queue there just to get a diagnostic test. So in the Enhanced Community Care Programme, we'll be providing those tests much more readily available for the GP to directly refer for those patients. So a ring-fence service and a quick service, because those, and as you will see in some of the programs that are going to be showcased today, that has radically reduced the need for those patients to go to hospital. So it's care in the community at the lowest level of complexity.
Yeah, and we're hearing, you know, patient feedback and simple things like not having to travel and pay parking fees in a hospital. I mean, honestly, these are the things that patients are saying. They're making such a difference to the experience of the care they're getting. And also, you mentioned the self-management. That seems to be a huge part for many
Absolutely.
of the chronic disease sufferers in particular, that they have a sense of getting back control. They know what they're supposed to be doing, and they have the local GP link if things should go awry. So we are seeing it.
And the feedback we're getting, and also you'll see showcased in the programs today, you know, easy access to those education and rehabilitation services like cardiac rehabilitation, pulmonary rehabilitation, diabetes self-management support is giving the patients that confidence and skills that they need to understand and to manage their own disease, and they really appreciate it.
Absolutely. Rachel, can I come to you? How are the healthcare professionals going to be working differently? I mean, in many ways, you know, enhanced community care seems to be happening and it has emerged during COVID. What has enabled it? What will be different and what has enabled it in your view?
Thank you, Grania. Well, I suppose the first key enabler in terms of working differently is in Ireland, we have a highly trained and highly skilled healthcare workforce. And that allows us then to reach out, spanning the wide spectrum of population health need, and then a huge knowledge of service delivery throughout the whole system that incorporates all the different areas. So we can maximize the expertise of our workforce then by integrating the roles and developing partnership approaches to care delivery as described by both Orla and Pat in their introductions. And through this, then health professionals can grow and work differently to adopt integrated team approaches where care is provided locally at the lowest level and appropriate level of complexity possible, with GP, nursing, health and social care leadership empowered to, you know, deliver care and then supporting further egress into the community. So partnership approaches to care can then be further implemented through remote models of care delivery supported by technology. And we've seen an awful lot of that recently during COVID. And this allows the acute professionals in that side of the system to integrate with the community health professionals and deliver care in the person's home as already described. And I suppose the models are further leveraged by technology. An example of this would have been the community virtual ward, for example, that was tested, where 85% of specialist care from acute hospitals was actually delivered in the community and home setting remotely using technology, which is an example of how healthcare professionals are going to work differently. Another example is with the rollout of the community health networks. This provides a framework for healthcare professionals to deliver care differently through population health management approaches and interprofessional partnerships, which is something that we've seen really grow during COVID. And this will enable specialist and generalist care delivery models supporting healthcare professionals to work at the top of their license, which is what we want to see. And I suppose lastly, what I would say is a big difference in the approach to care delivery that we will see is the success of things like the community call framework during COVID-19, where healthcare professionals and non-healthcare agencies integrated to deliver the population health care and care needs across the system really showed us that we can do things very, very differently.
Very good, really clear there. Thank you so much for that, Rachel. So maybe back to you, Orla. How is what you're proposing, how is it aligned to Sláintecare in your view?
Well, Sláintecare is asking the health services to shift left into the community and also to emphasise prevention. And that's exactly what the Integrated Care Programme for Chronic Disease is doing. It's basically providing the vast majority of care in the community and enabling people both from preventive services such as smoking cessation and so on, diabetes prevention programs and GP prevention programs to prevent a lot of the chronic diseases, but also to provide support for them and care for them when in the community when necessary.
Very good. And Pat, to you again, we see this is aligned to Sláintecare. We've heard what it will mean for patients and also for staff. I mean, at the end of the day, this really is about enhancing community care, is about making sure that people get right care, right place, right time. Are there challenges that you have already overcome that you want to just mention?
Well, there are challenges. We're having to establish 96 community healthcare networks and 30 community specialist teams. But an important part of that is to recruit over 3,000 staff. So there's 1,500 frontline staff will be appointed to the health system at community network level, 1,500 more across the community specialist teams for older people with chronic disease. And obviously doing that in the context of COVID and the cyber attack and so on, there have been challenges. But what we learn all of the time is the innovation and creativity of our local leadership right across all the professions. And what you see is a great willingness and capacity at a local level to actually overcome the challenges of the day. And I think we've seen that with COVID, we've seen it with the vaccination programme, and we're seeing it here with the rollout of the Enhanced Community Care Programme. So I think we will see that type of development improving and increasing as we progress. I think it's important also to mention our health and wellbeing initiatives. These will also be rolled out at network level. And I think, as mentioned earlier, we're going to roll out the alone type model at network level as well. So our voluntary partners are a really important part of this, and linking in with local authorities and other government departments. What's it all about? Ultimately, it's to make it easier for our service user and patients to access our services and to have them delivered locally. And I think that's what we're about here.
Exactly. And we're going to see that in action with the 4 projects that we're going to showcase now in the coming moments of the webinar. So can I thank the 3 of you for your time, for your expertise, and for the great work that you're doing. Thanks to all of you, and thank you for joining us this afternoon.
Thanks, Grania. Thank you too.
Thank you, Grania.
So I think a really interesting overview of what the purpose, the structures and the new practices of enhanced community care are, and also what this move will mean for care in a community setting as those 96 community healthcare networks get up and running. So let's go to the 4 projects who best illustrate enhanced community care and what we can expect in the field across Ireland as their work moves from pilot project supported by Sláintecare integrated funds to mainstream activity, again, supported by Sláintecare. Our first project for you this afternoon is in Galway, Accelerated Integrated Care for Older Persons. I spoke with the project lead earlier this week. So I'm very pleased to be joined now by Dr. Michelle Canavan, consultant geriatrician and clinical project lead in our project Accelerating Integrated Care for Older Persons. Michelle, we'll start off maybe with you. Just tell me a little bit about the background of the project. Why was it set up, and who makes up the team there?
So this project has been kind of in motion for a number of years, actually since 2018. Really, my colleagues here in the Department of Geriatric Medicine had been, and even before that, had recognised the need for integrated care for older people. So there was a kind of a committee working around in the background. And actually, just prior to the Sláintecare funding being announced, we had a meeting with Síolta, which is our kind of hospital group, and Community Healthcare West, which is the community Galway Mayo Roscommon, expressing the need for this service. And then Sláintecare funding came very timely, and thankfully we were funded for a pilot team. And so basically we got funded for a 0.5 registrar, clerical, senior physio, senior OT, a half-time speech and language therapist, and a case manager. And what we did with that service, or with that kind of resource, I suppose, was added to existing consultant time We had some AMPs and older persons to kind of form a team where we could get this off the ground. And I suppose our main aim is really to offer integrated care to older people, an alternative to coming into hospital where possible, trying to avoid the emergency department and trying to give older people that care as close to their home as possible. And that's one of our big ethoses in this team. And we're running a kind of we have a central hub here at the University Hospital Galway. And I have to mention the National University of Ireland, who give us rooms in their research facility where we hang out currently. Hopefully we'll be out in the community, you know, as things move on. But we're there, and then we've also started doing outreach clinics in the communities, and our colleagues in primary care teams have been really helpful in this and really receptive to this, because the feedback from our patients is that they really, you know, they much prefer having to go to their local primary care centre than having to come all the way into Galway with traffic and parking and all the usual stuff. So that's been really, really good, and I suppose that was one of our central kind of themes.
Great stuff. And where do your referrals come from?
So when we started off, we were kind of triaging referrals that we would have got to geriatric medicine in general, you know, because we were just starting off, we were trying to get our feet. But as we evolved, we set up a direct GP referral form, so the GPs can refer to us directly. And we have a criteria, which is, you know, as we've learned, you kind of, you know, it can get very big very quickly. So you have to be kind of clear on the criteria. But we try to see people who are over 75, living in Galway City or County, who need input from medical, nursing, and probably one or more of the other allied health professionals. And we try and concentrate on people who have a frailty scale of between 4 and 6. So they have some medical comorbidities, and they may not be so good in mobility, they may have cognitive issues. So we're trying to focus on that core group where we can intervene and make a difference and maybe do some assessment.
Very good. So in many ways, these they're new pathways that your project is developing, providing alternative routes for older people so that they can avoid acute hospital where possible, and indeed also, you know, emergency department referral, these places where nobody wants to be, but as an older person, perhaps, as you say, with frailties and comorbidities, they're just not good spaces for people to end up in. I understand as well that you're hoping that the work will enhance hospital discharge. So tell me a little bit about how these new pathways are working, and, you know, how does it feel from the patient's point of view?
So I suppose, you know, I have to mention the National Integrated Care Programme for Older People, where, you know, we've based a lot of our work on that. We've set up a governance group based on their structures, and that's been really helpful, because I think you need to get the building blocks in place, you know, to get things going. But certainly their ethos is you know, sending care, the shift to the left of care. And certainly we see that. You know, it's been a challenge with COVID, and more recently the cyber attack. And even getting people recruited has been challenging. So, you know, but we do see now people that are coming into hospital may have been seen by us. We're hearing about those patients, and we can arrange for them to get out of hospital quickly and follow them up. We're also working closely with our ED and AMAU colleagues, and they'll see people maybe that need investigations on the day they're in, and they say actually they need a comprehensive geriatric assessment, and we'll get referrals from there. And so that's working quite well. And also, because we're here as a service now and we have a direct point of access, we have our case manager, we have a dedicated email, and our admin, the GPs or the public health nurses can get in touch if they're worried about someone. And I suppose one of our outputs or metrics was to kind of, you know, some crisis admission avoidance. And oftentimes, I think we've managed about 17 so far, and we were looking at average length of stay for older people in hospital. For a moderately frail older person in Galway, it's 19 days, which is really long. So we've saved over 300 bed days, which is nearly €300,000 if you take 1,000 per bed day. And, you know, I suppose the funding we got from Sláintecare was 334,000. So I think we could say we paid for ourselves.
Your value for money already. Yeah. And tell me, Michelle, in terms of the clinics in Loughrea and Tuam, obviously those links to primary care centres are really important to the success of the project. Just talk a little bit about those, and maybe even some of the challenges in getting them up and running.
Yeah, I think we had already kind of started a pilot project in Loughrea, and we had been in the community nursing unit there because one of the AMPs that I work with was based there. And so that was successful. But then when COVID came, we were like, okay, we can't actually be in the nursing home, you know, bringing patients in and out. So we actually went to our colleagues in the primary care centre there who really, you know, received us. And so they've given us a slot there every month. And similarly up in Tuam, and the GPs there have been very helpful. but its space is a premium at the moment with COVID, and that's going to be an ongoing issue, and particularly with the investment in the ECC funding, where all these teams are going to sit and go, particularly in the interim, I think is going to be a big challenge. But from the patient perspective, they love it. They find it much more accessible. They seem to feel more relaxed as well. I think we underestimate how big a deal it is for an older person, particularly, to come into a tertiary referral hospital, even finding their way around. Little things like that make a big difference. So already you have someone at their ease. And I suppose the other thing we've been doing, where we need to, is going out into the home and doing some home visits. Our advanced nurse practitioner would do that a lot, and a lot of our consultant colleagues would do home visits for people who can't kind of come in, but GPs are concerned. So it's kind of a hybrid model. We're fine-tuning it all the time, but it seems to be working well. Yeah.
But I mean, it really is, representative of the Sláintecare, right care, right place, right time, and depending on the situation of the older person, like going into the home. I mean, that's brand new for so many people, and a new element of the service. So it's great to hear about that. In terms of outcomes at this stage, any outcomes you want to share with us? What kind of outcomes are you seeing?
Well, we were, it's hard, I think, when you're setting up a project. You always say, well, I probably revise the outcomes I would have had at the start. But we had aimed, based on the national programme metrics, to kind of manage about 1,800 older adults through the hub. Now, we revised that down with COVID up to 1,500, but actually, at last count, I think we're about 1,700. And despite stops and starts, and we had a few months where we weren't running any clinics because actually most of our staff were diverted back into the wards to look at COVID, and in the community they were doing testing. So there was times where we had no team, but it's a testament to the team that I work with. They found ways, even the cyber attack, we managed to keep clinics going, and I can't thank them enough. They've been phenomenal.
Brilliant. You mentioned COVID a couple of times already. Just briefly, did you have to adapt? I know staff were sent hither and yon, but it did have an impact, yet your outcomes are still way up there.
Yeah, I think we did try and adapt. We took on the virtual thing at the time. We were like, oh God, how are older people going to adapt to using technology? But a lot of older people, even their carers or their families, can kind of set things up for them. They've become quite au fait with Zooms because they're family all over the world, and
Yes.
it's been really good. It doesn't work for some people. Hearing is a big problem trying to do things. And it's very difficult to do cognitive assessments and stuff like that virtually, but particularly for patients we would know well and we need to check in on them, it's been really useful. And I think some of the things we did during the time were, so we kind of did a mixture of home visits, virtual visits where needed, and even as our speech and language therapist and OTs developed an online reminiscence program, a little pilot program where reminiscence therapy is often done in groups, with people present. But they actually did it online and found it, and the patients we had put in, I was going to go, I don't know how this is going to go, but they really enjoyed it. And the feedback was very positive. So there are things that can be done easily that we can learn from going forward, because the idea of bringing people into big groups, I suppose, is not probably going to be feasible for the long term. So we need to kind of think of new strategies around it.
Right. So actually some new opportunities arising out of what has been a dreadful period for most of us.
And I think just, working with people where you might necessarily know, our governance group has lots of representatives, even from our healthy aging in the county and city and Galway City and County Council. And they actually came to us during the time they were trying to do a Keep Well booklet for older people during COVID, and we were delighted to be involved in that. Our physio did kind of the exercise program in it. We did some videos. So, it's just working with everyone around you, because everyone has the same aim. They want to look after older people and improve their outcomes. So that was another good learning, people just pull together.
Yeah. So Michelle, finally then, as you know, all of the 4 projects that we're featuring in today's webinar have been selected for mainstreaming. What impact will that mainstreaming decision have now for services for older people in Galway?
I think we could see from some of the feedback we got from patients, and probably be coming up on some of the slides, I hope I can continue to attend this service. So I hope we can continue to provide this service. But I think the fact that we have the ECC funding, and we'll be able to expand our existing team to a full multidisciplinary team with therapy assistants, with the addition of dietetics. We have an operational manager, and we also have we've been funded for a full team for the East Galway Roscommon side. and we're working with them and Portiuncula Hospital and Roscommon Hospital and the community there to try and get it going on that side as well, because they have a really an older population there that really has a need for this service. So the fact that we're actually funded and we can crack into that now is brilliant. And I think long term, older people want to access these specialist services, and they should be accessing specialist services, and we should be able to provide that outside the community. And I think the ambulatory hubs, when they're set up, will make a big difference to that, in that there is a kind of a central place for them to go if they need investigations. But also I think we'd retain the hub and spoke type model, because that works very well locally. And a big kind of one of the areas where we anyone from the west of the county or towards the islands tends to come into the hospital at the moment. So we'd like to set up some spokes out in the kind of Connemara, Clifton, and maybe just have access for those patients. Because again, it's bad enough coming to the other side of the city, but when you're coming across boat and land and sea and all sorts, it's a bit more difficult.
It's a trek. Well, Dr. Michelle Canvan, best of luck with the project, and well done on all you've achieved so far. Thank you so much for joining us today.
And thanks to Sláintecare for the funding. We really appreciate it. Thank you.
So thanks to Dr. Canavan there in Galway, using the spoke and hub approach to developing integrated community services for older people, echoing both the need and the solutions as discussed earlier in our panel. The second project for you this afternoon is Donegal Integrated Service for Heart Failure. I spoke with two members of the team there earlier in the week. Heart failure is one of the major chronic diseases in Ireland today. Some 3,200 people in Donegal have a diagnosis of heart failure annually, with the same again having asymptomatic left ventricular dysfunction. Heart failure is one of the most common reasons for hospital admissions of those over 70. So finding ways to enhance care in the community and improve health outcomes is a major challenge. I'm delighted to welcome members of DISH, the Donegal Heart Failure Integrated Care Service, this afternoon. Owen Sheehy, Chief Cardiac Physiologist, and Karen McCafferty, Heart Failure Clinical Nurse Specialist with Integrated Care. You're both very welcome. Delighted to have you with us this afternoon. If I can come to you first, Owen, and ask you, what did you set out to achieve with this project in the first instance?
So, Gráinne, we set out to achieve an integrated service for the people of Donegal living with heart failure, those suspected of living with heart failure. And the project is based on the HSE's clinical care programme model of care. And we set out to provide GP access to specialist nursing care and to timely diagnostics in a community setting. And we felt that the addition of an advanced nurse practitioner would support the cardiologists by providing specialist review and follow-up of patients who were admitted with heart failure. And our overall aim really was to provide support for those patients with heart failure and to reduce the amount of admissions and the length of stay of admissions.
Very good. And I know you're based in Donegal, but where are you currently located, and do you plan on expanding the service for the entire county?
Yeah, so initially we set up in Letterkenny, and we're very lucky to have access to the COVID Community Hub, which is based in Letterkenny, and they're very kindly offered us clinical space there within the hub. So that was our first location. And then we moved on, then we've set up 3 spoke locations since that time. So we set up in Carndonagh, which is about 60 kilometres north of Letterkenny. And we've also gone to Dunlow, which is about 50 kilometres to the west. And we've also accessed into Donegal town as well. So now we kind of have a hub and spoke model for the service. So it's working out very well.
Very good. And you mentioned COVID there. Did COVID change the outputs? Did it change what you had to do? How were you affected?
Yeah, I mean, I suppose COVID's affected everybody in some fashion, unfortunately. Yeah. It has changed some of the timings and the direction of the project. But funny enough, it's probably in some senses benefited the project. So initially we had planned to have 4 GP practice locations. And because of the inaccessibility of getting into GP practices during COVID, and particularly during the waves of COVID, we reached out to the community hospitals, and that's where we were able to base our our spoke clinics in the hospitals. So actually we've increased our access to GPs, so all GPs now have access to the service. And I suppose the other main thing we've introduced is the nurses have brought in virtual clinics. So we're using Attend Anywhere and phone for clinics as well. So it's working out very well.
That's interesting. We've seen that with a number of projects who've had to pivot to change what they had planned to do. And many of them are saying what you're saying, which is actually we're seeing maybe, you know, enhanced service or moving to a more blended model. And that seems to be the approach you've taken. And I'm sure it's benefiting patients. If I can come to your colleague then, come to Karen. Karen, where do referrals come from for the work?
Well, initially, in order to get the service established, we looked at the existing heart failure hospital waiting list, and we identified patients from that waiting list who needed a review, possibly hadn't been reviewed in a number of years. So we've seen those patients, therefore reducing that waiting list. And we also have taken patients that had a recent hospital discharge in order for them to get seen in a timely manner closer to their homes. And while we've been doing this, during that process as such, we established the project implementation group in order to get the clinical pathways approved. And once the clinical pathways were approved by our clinical lead, Dr. Santosh David, we then looked at the referral pathway and the communication with the GPs. So initially we had thought that referrals through an email would be the most efficient form of referral. Because a lot of the GP practices in Donegal have a heart failure referral form embedded into their software. But on further consultation with the GPs, we realised that the HealthLink referral was much more efficient and much more user friendly. So that is what we set up for the GP. So it's a HealthLink referral, and it's working out very well at the moment.
And what are the GPs saying about the service you're providing? What kind of feedback are you getting from them?
Well, I have to say the GPs have been overwhelmingly supportive and receptive of the service, because their workload over dealing with a COVID pandemic and also with the rollout of the vaccination programme has made their service very busy and has limited our access to the GP practices, as Owen has alluded to there. But I have managed to visit 28 of the practices in order to discuss this new exciting service with them and to answer any of their queries, and also to deliver our new directory of services to them. Now, they're very keen to utilise the service and they welcome it for their heart failure patients. But it is very evident from speaking to the GPs that they would really like this ECHO service in particular to be expanded. And hopefully that is something that we will be able to do in the future with the new enhanced community care programme. You know,
what's the ECHO service? Just tell us what that is.
So the ECHO service, it's an ultrasound of the heart, and it helps in the diagnosis of heart failure.
Okay, so if everybody had access to that across the county, they're saying it would really enhance the service to the patients. And Karen, in terms of the difference now, like if I was somebody with heart failure and say I'd had this condition for a number of years, how is the service you're providing? How does my pathway look different now that you're on the scene? What difference is it making to the patients?
Well, really, it has had a big impact to the patients, and the feedback from the patients has been very positive. Even from the aspect of as part of the project, we have been recording the travel times for the patients. And initially, a lot of these heart failure patients who have a lot of other comorbidities and tend to be quite elderly have had to travel to Letterkenny University Hospital for all their follow-up appointments. And on average, the travel distance for these patients was 108 kilometres prior to us setting up this service. And we have reduced that to 33 kilometres. So that is a saving of 76 kilometres per visit. Yeah, it is very significant. But cost seems to be a big implication for a lot of the patients. A lot of the feedback from the patients is that for instance, a gentleman that comes to the Carndonagh Clinic, when he goes to Letterkenny, it costs him €80 in a taxi. Where he comes to Carndonagh Clinic, it costs him €14. They also talk a lot about parking charges in the hospital, and the 4 community sites that we have established at the moment have no cost for parking. So they tend to be keen to come and see the heart failure nurse as opposed to going to the GP. One of the gentlemen that we had wouldn't go to the GP, but he would come and see the heart failure nurse. And we try and accommodate the patients. For instance, we had a lady who was on night shift, so we seen her early in the morning in her own hometown. And as it turns out, she would never have travelled to Letterkenny for that appointment. So we're getting a lot of positive feedback from the patient. So all in all, it's good.
Very good. And clinical outcomes, are you able to measure those? Can you see them in reality?
We have had to make some adjustments as a result of COVID, but however, as Owen has alluded to, we have established the 4 community clinics, and this has given us a wider reach to incorporate all the GPs in Donegal. And the project, the amount of reviews that were predicted or projected for this project has been exceeded, but that really is because we're seeing patients off the waiting list, and we're also seeing post-discharge patients. So and as well as that, we've set up this project in the middle of this COVID pandemic, and now we're faced with the cyber attack. And throughout all of it, we have continued with our virtual clinics and our face-to-face clinics, including your titration, disease modifying titration, and education and self-management, and also dealing with acute decompensations for these patients by increasing diuretics. And this does have a direct impact on hospital admissions. And really, I think the added value of having Owen, our cardiac physiologist, to the service, not alone for his echo expertise, but a lot of these patients have devices in situ like CRTD and AICDs, and Owen has the capacity to access the data from these devices, and this all contributes to our clinical decision making and therefore our treatment plan. And I think as well as that, the benefits to the patient from having an A&P on the service is just phenomenal, because those clinical decisions can be made at community level. And we have noticed actually from the project, anything that we're taking back to the cardiologist has really been for advanced therapies, for instance, like device considerations or angiography or cardioversions, things like that. So I think the integrated post really does encourage like a shared care between the GPs and these specialist teams, and this can only enhance the care that we're giving to the patients. And really, at the end of the day, this is about the patient, you know.
Exactly. So finally, maybe in terms of, as we're saying, all of our projects that are on this afternoon are all mainstreamed as part of the enhanced community care strategy. What will the mainstreaming of your project, what will it mean for you and your patients?
Well, as you can see from what we have said already, this service really benefits the patient. It brings the service closer to their homes. They don't have the same travel distances or the stress that's involved in coming to the hospital. And as I said, all the feedback is very positive.
Well, it sounds like you're making great ground up there with this initiative, and we wish you the very best as you go on with your journey being mainstreamed. Thank you both for joining us this afternoon, and best of luck with the rest of the work. Thank you so much.
Thank you, Grania. Thanks
so much. Thanks for having us.
Hello, Kieran O'Farry here. I'm a GP in Millbrae Surgery in Stranraer. From my point of view, from a general practice point of view, I think the Donegal Integrated Heart Failure Service has been a fantastic success. I've had the opportunity to refer a few patients, and the service provided, the speed of access and the location has been fantastic. We've got great reports back, and I think the direct access to early echocardiography for patients with potential heart failure has been brilliant and long overdue, and it's a great service, and I hope it continues, and I hope it's expanded on going forward. Also, some patients who've been admitted to hospital were followed up by the service on discharge, which I found particularly helpful and has reduced our workload, and I think also improved patient care. So well done, and I hope it all continues into the future.
So GP Kieran O'Farry there finishing that video and telling us how the service is. He says a long overdue service improving patient care. Good example of enhanced community care developments there in Donegal. The third project this afternoon is in the field of respiratory healthcare. Let's hear now from the change manager with Respiratory End-to-End Model at Two Sites project. a disease of the lungs, COPD, chronic obstructive pulmonary disease. It's estimated that in Ireland, almost 500,000 people over the age of 40 have COPD, but many are undiagnosed. Hospitalisation rates for COPD sufferers are high, but I'm glad to say they are declining recently. I'm pleased to be joined this afternoon by Mairead Ward. Mairead is the change manager with end-to-end respiratory model at 2 sites. You're very welcome, Mairead.
Thanks, Grania, for having me on today.
Delighted to have you. Mairead, would you start by telling me a little bit about the project? What service are you providing and in what parts of the country?
So the project is a respiratory end-to-end model, and it's being provided in 2 sites in the country. So North East Wicklow, so that's kind of encompassing the large towns of Bray and Greystones and the surrounding area. And then it's also being delivered in Longford Westmeath, so throughout those 2 counties. So basically each site is made up of a team of 4 disciplines. So there's 1 respiratory nurse specialist. There's 2 who, the respiratory nurse specialist, her role is providing a respiratory service to the COPD and asthmatic patients, whereby she's going through an assessment and medication review and providing self-management strategies. And the respiratory nurse specialist also runs a clinic along with the respiratory physiologist. So we have a senior respiratory physiologist on each site who is delivering diagnostic spirometry. So it's the first time in Ireland that diagnostic spirometry has come out into the community. And then also there are 2 senior physiotherapists on each site, and they are delivering pulmonary rehabilitation in the community. And they're also doing one-to-one respiratory physiotherapy assessment and treatments. And then also we have a health promotion and improvement officer on each site, and their main role is for smoking cessation in each region.
Very good. And just go back and tell me a little bit about the innovative element, which is the spirometry service. What actually is that? What does it entail?
So spirometry is spirometry is a diagnostic measure, and it's performed by respiratory physiologists, and it actually aids in the diagnosis of COPD or asthma or other lung conditions. So basically, we have a portable spirometer that the respiratory physiologists are using in the community. And I suppose with that, then they're getting referrals from GPs. I suppose that's one of our main roles, is all about engaging with GPs and primary care. And they are, from the results, then they're linking back with the consultant in secondary care if needed, or else they're just sending the results back to the GP, where they're making diagnoses of COPD or asthma. Now, there are a small cohort of patients who unfortunately might need further testing, if it's something a little bit more complex, if it's a restrictive lung disorder. So that actual respiratory physiologist also works 1 day a week in the hospital. So they follow the same patient up in the hospital in the pulmonary function test lab to do the further tests linked with the respiratory consultants in secondary care. So far, I have to say the feedback has been fantastic. I suppose particularly down in Longford Westmeath, where I suppose it's a little bit more rural than our other site, where definitely the patients in Longford had to travel long distances to Mullingar. They are absolutely delighted to just be going to Longford for their spirometry. Yes, and so it just has been met with, I'm very satisfied with the service. All the patients are, and there's approximately 50 patients being managed on each site in the diagnostic service since we've become operational, to kind of Q1, Q2 this year, into Q1, start Q2. Yeah.
Very good, Mairead. And tell me, in terms of the background of the project, was there a previous service operating and did you build on it, or was this something you had to create from scratch?
In Northeast Wicklow, there was no previous service. So every service that came, we had to build it on from scratch, which included engaging with the GPs and everything. But however, down in Longford Westmeath, there was a service. So for pulmonary rehabilitation, the COPD outreach team also, as long with doing outreach and managing oxygen clinics, also did pulmonary rehabilitation, but they were very stretched. And also there was a clinical nurse specialist covering both counties as well, who was stretched. So in Longford Westmeath, we have been building on existing services. Example, in pulmonary rehabilitation, we actually took most of their waiting list, which consisted of 200 patients on a waiting list. But up until last week now, it's actually been reduced down to 102 patients. So some patients were waiting almost 5 years for pulmonary rehabilitation, and it's reduced down now, just in the couple of months since we've been operational, down to 2.5 years. So we're hoping to get it well within the year by the end of the year.
Very good.
Yeah.
Very good. So you spoke there about GPs. Is that the key source of referrals? Is that where all of your referrals come from? Where do they mostly come from?
So I suppose one of our outputs for this was all about engaging with the GPs, kind of as a platform for the enhanced community care models that are coming on stream. So therefore, that was kind of one of our strong aims, was just GP engagement. So therefore, we actually got set up on HealthLink. So therefore, that GPs could find it easier to refer to us. But unfortunately, the past few weeks with the cyber attack, that has been a bit. But it's been interesting in that the team report that the GPs have come back to paper. You know, because we've already built up the relationships with them, still referring. So first week there was no referrals of the cyber attack, but since then it's come back to paper, I'm afraid. But hopefully we'll get back up onto HealthLink again. But GPs are providing a huge amount of our referrals, which is great. Also the team are referring to each other. So I suppose sometimes when the clinical nurse specialist is assessing a patient, and then she decides she might refer to the smoking cessation service or refer to the pulmonary rehabilitation service, or often enough it's the joint clinic being done with the respiratory physiologist, might find that this, there's been a lot of inter-referral within the team. So it's kind of been fantastic to have the team approach. And also as well, we are receiving referrals as well from the acute services who we are integrated with, so.
Very good. So you have that integrated approach, which seems to be really working. And tell me, are you operating in the hospitals or are you out in the community? So are patients coming into the hospital for treatment, or are you doing it out in a community setting?
We are doing it out in the community setting. So the nurse specialist is based in primary care centres, so she's seeing the patients there. The physios are operating, I suppose they were virtual at the start of the year, and now they've resumed face-to-face with careful infection control guidelines. Sure. The respiratory physiologists are out in the community now. They do work 1 day a week in the acute hospital to maintain their skills, but also as well for that small cohort who may need the further testing. They're meeting, so that has worked really well, and we've got good feedback from patients that they're meeting the same person, But the majority, I suppose 90%, 90-95 of our work is in the community. And smoking cessation is just the one thing that I haven't said. They are actually very much online. And I suppose it's actually the feedback that we've gotten from patients is that they actually prefer the online nearly than it's just easier access. I think smoking cessation out of all the services was the one that easily transferred to transition to online.
Yeah, no, that's interesting. Some elements of some of the programs actually seem to be really well suited, and patients prefer the online in some ways. Tell me a little about any reported outcomes to date. You mentioned some numbers earlier on. Talk a little bit more about the outcomes that you're seeing so far.
Well, I suppose one of our outcomes was about we're trying to engage with eight GP practices a month, so across both sites we are achieving that, where we are now. We have one practice in Bray that consists of about 12 GPs, so it just happens to be quite big, but we still only put it down as one practice. Okay. But yeah, we're lucky that in Longford, Westmeath is a bit rural where there are smaller GPs, so we're kind of between the two sites where we are engaging with the GPs. And as we said, we thought when HealthLink went down that we wouldn't get any referrals, but the back to paper. So that, and our other outcomes was as well about delivering pulmonary rehabilitation classes. So initially, as I said, in Longford, Westmeath, they inherited a huge waiting list of 200 patients, and it's, they've still been getting referrals every month, about 10 a month, but they've reduced it down to about 102. In North East Wicklow, because it was a new service, we had to build up from scratch. We did get about 10 to 50. We got about 10 patients from the acute sector, but the GPs there have been referring an awful lot of patients to pulmonary rehabilitation. So that was kind of, I suppose, slightly different. So they did a lot of work in North East Wicklow with GP engagement just to try and generate referrals. But so far, so we, as I said, with pulmonary rehabilitation, we were delivering initially online our classes, but so we have now, I suppose, with the cyber attack, that was kind of stalled for a couple of weeks, but that is back up again. And also then we finally resumed our face-to-face classes. only thing I suppose that's kind of a challenge is we just have to have smaller numbers in our face-to-face classes than what we used to have because of social distancing. So we're actually doing more classes than what we would have done, but I suppose just to try and I suppose get the throughput.
Exactly, to reach the numbers. But again, that's interesting, that kind of pivoting for COVID,
Yes.
smaller numbers, but then you're trying to reach the targets by holding more classes. So that's great. Tell me, what are the patients saying to you about the service and the impact it's having on them? What kind of feedback are you getting from them?
Oh, so the feedback has been fantastic. Like I, talking to all the team members there just before our call, like we actually don't really get any negative feedback, which is fantastic. And even in, I suppose, Northeast Wicklow, which isn't too far from Dublin, just where patients would have been going to, they just say, please keep the service in Bray. We love it. It's just so much easier. Then in Longford, Westmeath, the Longford patients are delighted not to be having to travel to Mullingar. And so basically the feedback has just been, it's been extremely positive. And I suppose even some of the patients then who have had to go to the hospital, for further testing, again, sometimes the nurse is linking patients into the consultant for, I suppose, some of those more complex patients. Again, I suppose the feedback has been very positive because I suppose because it's an integrated approach, it's all happening a bit quicker maybe than what they might be used to, because the nurse also attends one of the consultant clinics a week. So she kind of brings the patients to that clinic for the consultant. We just have a small number that we can kind of allocate into that clinic every week. And so I suppose they're seeing the integrated approach, and the feedback has been extremely, extremely positive. And they're liking that most of the services are in the community, and just the odd thing then, I suppose, more complex thing then has to be moved on to secondary care.
Sure. And I guess as well, one of the aims is, if you're out in the community and you are using your tools to diagnose and to reach people, you're getting earlier diagnosis. So therefore, I'm presuming the treatment is less complex the earlier you can capture. Are you seeing that in your outcomes yet?
Maybe not quite yet, but I suppose that is all our reason of trying to engage with the GPs. I suppose by the time the patients are with the consultants, they're generally a little bit more complex and a little bit more progressive. But that's the whole idea of engaging with the GPs, and I suppose trying to get that little bit earlier on. So, but the respiratory physiologists are starting to say that the majority of the caseload that they're seeing are the very early on COPDs who are just being referred back to the GP just for early management, and being referred, as needed for smoking cessation, or even to the nurse for self-management strategies, and just, I suppose, for education around their disease and tips that they can do to, just to manage their chronic disease.
Exactly. And all of those self-management and information linked with the GPs will probably ultimately mean you will have fewer people going to the acutes, fewer people needing hospitalization. So all of that is really good, and both time saving, cost saving. And let's face it, nobody in COVID times or other times wants to end up in an acute hospital with this disease. So I know that you're one of the projects whose work is being mainstreamed. How do you think having it mainstreamed is going to impact both on the project, but also on COPD sufferers more widely?
Well, I suppose initially, this project, there was huge gaps across the county. It was very sporadic. Some counties had some services, some counties had others. So I just think the investment into COPD and the other chronic diseases is going to be instrumental in, reducing, hospital admissions, and I suppose just providing that level of care that is closer to home, that and again, trying to target patients when they are that little bit earlier on in their chronic disease, when they're a little bit less complex. And again, going back to the root of the GP, and just trying to keep all of it close to home. So, the investment is fantastic. It's going to be great to have so many other teams coming in around the country, and even our team is going to be, I think, tripled in size. So it's fantastic.
Right. So it sounds like it's really the right move in the right direction for you, for the team, and most importantly, for those suffering from COPD. Mairead, thank you so much for joining us this afternoon, and the very best of luck with all your good work. Thank you.
Thank you.
So good news there from an initiative which will have huge benefits for sufferers of the chronic disease COPD. as the supports and the care move into the community. Turning to our fourth project this afternoon, end-to-end implementation of integrated care for type 2 diabetes within 2 CHOs. I spoke with the change manager and the consultant endocrinologist involved in this project. People with diabetes is growing year on year. Diabetes, as you know, is a condition where the body cannot regulate levels of glucose in the blood. Type 1 generally develops in childhood or adolescence, and type 2 more often develops in adults. It's a dangerous disease which, if poorly managed, can have very serious health consequences. It's expected that the number of people with type 2 diabetes will increase by 60% over the next 10 to 15 years. I'm very pleased to be joined this afternoon by members of the end-to-end implementation of the model of integrated care for type 2 diabetes within 2 community health networks. Firstly, Professor Sean Dineen, consultant endocrinologist and national lead for the diabetes clinical programme. You're very welcome.
Thanks.
And we have your colleague, Lorna Hurley, who is the change manager leading the project in the 2 CHO network sites. If I could come to you, first of all, Professor Dineen, would you tell us a little bit about the background to the project? What type of service was in place previously? And what is your end-to-end service that you set up?
Thanks very much, Grania. So diabetes care in Ireland has traditionally had a hospital focus, and we have, prior to this project, we had appointed and initiated some community-oriented diabetes care through about 32 clinical nurse specialists who were working really as in general practices, supporting practices, links back to the hospital, but it was very ad hoc and very scattered around the country. These nurses do fantastic work and have been doing fantastic work. They're really pioneers, but it was a challenge, and the system was not as joined up as it could have been and should have been, probably. So the Sláintecare Integration Fund project that we're describing and talking about has enabled us really to make that care delivered by a team. It's helped us to realize that. So we have appointed teams in 2 networks, one in Galway, one in Cork, and the end-to-end term really reflects that the skill set of the team allows for all care, from prevention, through to the more complicated end. I should point out that our model of care for type 2 diabetes calls for uncomplicated type 2 diabetes patients, with stable type 2 to be managed in primary care, and then patients with type 1 or very advanced complications managed in the hospital. And it's that middle group of patients with type 2 with some degree of complication that we're really focusing on in this, and so supporting practices to enable them to deliver more care and to have that link with the hospital.
Okay, so a community-based care, but with the link to the hospital is a kind of a shorthand for that. Okay, yeah. That's great. Thank you for that. Lorna, can I come to you as change manager for the 2 sites? Talk to me a little bit about what was involved in setting up this kind of team community-based service, and maybe any COVID-19 challenges that you had to overcome given the year we've all been through.
Yeah, we initially set up 2 local project teams, one in Galway and one in Cork, and it was important that these teams have representatives from all of the key stakeholders involved in diabetes care, the multidisciplinary team, as well as hospital and primary care management, and of course patient representatives as well. So these teams have met on a monthly basis since the project started. And together, really, we've worked to co-design the service. So, as a group, we've worked out and figured our way through issues regarding network boundaries, because this is a new way of working to a network boundary. And we agreed eligibility criteria, referral pathways, referral processes. So this was done on a team level with the local project teams. And it's been particularly helpful to have input from established CNSs and established dietitians and podiatrists that Prof. Deneen mentioned there earlier, that have been doing this for a number of years, because they have a lot of local knowledge that they can bring and they can share. So we engaged heavily with these local clinicians who could share their knowledge and help guide us. We also used the Health Service Change Guide, which was a really fabulous resource and a practical resource in guiding us in terms of setting up the service, in ensuring that we're all clear on the vision for the new service that we're trying to deliver, and then helping us put in place some actions to ensure that we bring our plan to fruition. And then once we designed the service, the team set about promoting it and linking in with GPs and practice nurses locally, forming relationships with the GPs. And you mentioned challenges during COVID. That was certainly a challenge, because GPs and practice nurses were stretched beyond capacity. And this took the form of face-to-face visits. Other times it was Zoom calls or webinars. But I have to say it has been really, really well received.
Excellent. That's great. And back to you, Prof. Deneen. How does the community team actually integrate with the hospital team? What are the challenges? Because one is operating in a community. Oftentimes, GP surgeries are independent kingdoms, and trying to integrate with the hospital team. What are the biggest kind of clinical challenges around that?
Yeah, it's a really good question. And I mean, I've been interested in integrated care for a long time. This project has really helped me get down and dirty, as it were, just get that. And I would say that there are lots of challenges. Our system isn't set up, well for integration. ICT, IT systems. We've been fortunate in Galway in that the clinical information system that we use in our hospital, we got additional licenses to enable the community-based team to use that, and that has been a huge help.
They just can talk to each other.
Absolutely. Yeah. I mean, they don't even have to communicate, because it's the same system.
Yeah.
So that we weren't able to use that in the Cork site, but we did explore using a system that's already in place in Cork, used by podiatry, and try to integrate across the teams. And we learned that wasn't feasible for a variety of reasons. It was cumbersome, it was challenging, but the integration at IT level in between the primary and secondary care in Galway, I'd say, has been a huge success. We also integrate by having the nurse and the podiatrist spend a day, the community-based nurses spend a day a week in the hospital. That's been hugely helpful. Just conversations, they obviously participate in the clinical work and they see patients, but it's about building those relationships and those bridges, and that's proving really, really helpful. And then the MDT aspect of it. So we've learned through COVID. You asked about COVID earlier. I mean, there's been so many negatives, but a positive has been that we have fortnightly meetings now with myself and two of my consultant colleagues, one here in Galway, one in Portiuncula, and we link in by, I'm not even sure which VC we use, but we link in and we discuss cases. And that has been tremendous. Learning in both directions, I have to say, because, oftentimes the patients that the nurses bring are patients who would never get to the hospital for reasons of frail elderly. We've pulled in our ICPOP colleagues at times, our older persons. We've pulled in psychology. It's just, it's been tremendous in terms of and I think that the key element for us, going forward, and maybe the piece that we're missing at those MDTs, is the GP involvement. GPs struggle obviously with time and because they're independent practitioners, but we're hoping that we will get support for these initiatives as we roll out the program to get GPs to participate, because they are said to be generalists. They're actually specialists. They're specialists in multimorbidity. They're specialists in complex frail elderly. They have a specialism that we really need in chronic disease.
And they also oftentimes have that long-standing relationship with the patient.
Absolutely.
With a wealth of additional information that you might only pick up by accident.
They know the patient, the family, the community, everything.
Exactly, all of that. So Laura, back to you. Tell us a little bit about some of the outcomes you've had from it, and maybe a little bit about what the patients are saying.
Yeah, sure. Well, we're very lucky in that over 90% of practices within both networks are actively engaging with the service, and that's just within the first 9 months. So that in itself, I think, tells a lot. In terms of formal evaluation of the project, it's ongoing. So we have partnered with UCC and NUIG, and we'll be evaluating the project formally, and we'll soon be able to release that data. Great. But what I can say is that we're exceeding targets in terms of new patients seen and review patients seen by the dietitian, by the podiatrist, and by the CNS. The dietitians are actively delivering self-management support programs like Desmond and Discover Diabetes. And in spite of COVID, we're meeting those targets. So they're now been delivered virtually instead of face-to-face. So we've had to adapt our mode of delivery, and that's going well. As I said, in terms of GPs engaging with the service, we're exceeding again expectations in that regard. So 90% of practices, so 10 out of 11 practices in Galway are referring to the service. 18 in Cork are referring. And in terms of patient feedback, we will be formally evaluating this in terms of a survey and interviews, but the initial findings from the survey would tell us that patients are saying things like amazing, exceptional professional care from my nurse specialist. Nothing was too much trouble for her. And the other thing that stands out, or the other comment, is the fact that I was listened to and it was a collaborative interaction on each visit made it so great. Patients liked the fact that appointments were prompt, they were delivered locally near their home, and that the parking wasn't an issue and that they didn't have to travel. So I think the final comment that sums it up nicely is the support I received was beyond all expectation. So, really it is right care, right place, right time.
Great comments as well. Just to finish, Professor Janine, if I can go back to you, I know you're the national lead for the diabetes clinical programme. You've been selected, I know, for mainstreaming under the enhanced community care. What do you see the vision for the overall impact of this now that it will be mainstream?
Yeah, it's a really exciting time. I've been interested in community diabetology, as we're now referring to it, or integrated diabetes care for many years. And it just feels like the planets or the stars have aligned, with Sláintecare, with COVID, and especially with the chronic disease management component of the new GP contract. I can't emphasize enough how rewarding it has been for me as national lead to work alongside people like Diarmuid Quinlan and Suzanne Kelly, our ICGP leads. And that's what we need. Our patients will benefit from joined up thinking at the policy level and joined up care on the ground. And we are realizing that through this Sláintecare project, but also through the enhanced community care. And the learning is huge. I mean, geographical boundaries, I never thought of it as a hospital-based specialist, but is it the address of the person or is it the address of their GP? That might seem like a silly question. It's not. It's really important. How are we going to organize ourselves? The IT infrastructure we've mentioned, but this word health informatics, or this phrase health informatics, I am so keen to understand it better, because it's about organizing ourselves well, getting a handle on the population. And it's that public health perspective. We've had it in bucket loads with COVID, but we need it for chronic disease. I think there's learning across ICPOP and, from our colleagues in older persons. There's also referral pathways. And it's not just referral in, which traditionally is what it's been. It's also making sure that we transition, stable patients back to the community. So we have a lot of different strands to this, but it is a very exciting time, and I think we're going to change the whole landscape of diabetes care in Ireland. I say that, and you might say, well, he would kind of say that, but actually, I believe that's going to happen over the next 5 or 10 years, and it has to happen because what's coming down the track, as you mentioned in your introduction, Grania, we have to get our act together.
Yeah. Absolutely. And it sounds like you have. Very best of luck. Great work. And thank you so much for coming on this afternoon to tell us about it. Thank you very much.
Great. Take care.
So, an approach that will change the whole landscape of diabetes care, Professor Janine says there, not least because we have to. Superb examples of enhanced community care work. So, You've heard about the 4 enhanced community care projects, all funded by Sláintecare Integrated Funds. And I now have a panel drawn from the projects with me, and we are taking questions. Some of you have already been on and have sent in your questions, and I will put them to the members of the panel as they come back and join us now. So I'm delighted to welcome back Dr. Michelle Canavan, the consultant geriatrician and clinical project lead with Accelerating Integrated Care for Older Persons. I'm also happy to welcome back Kathy Farrell, the advanced nurse practitioner from the Donegal Heart Failure Service, Mairead Ward, the change manager with the COPD Respiratory model project that we heard from. And I'm also joined by Lorna Hurley from the change manager of the diabetes end-to-end project that we just heard a few moments ago. So there are some questions coming in. I'll just have a look at what people are saying here. Michelle, there was a question for you in terms of the work that you're engaged in from a participant. They wondered what sort of inputs were received from older people themselves and how much emphasis is being placed on older people identifying their own needs. A good question.
Yeah, it's a really good question, and it's something that we've talked about a lot, actually, because the whole point of this, and when you're shifting care to the left and to the left, it is about empowering people to take control of their own healthcare, and empowering older people in particular to do that, because they may not have had the tools or the access to services that they can do that. I suppose our first step as a project to do that was to get their feedback. And I think that's kind of tied into that question. But what we did was we sent out a survey, a written survey. There was like some general questions about how they viewed the service, what was good, what wasn't good, what could we work on. And then we asked some questions about how they felt COVID had impacted on them, because we felt as a service that COVID has, inordinately affected older people, particularly with the cocooning initially, and then the effect on all the services that they would use normally. So that was really informative. We sent out 150 surveys. We got back 67, which isn't bad going for a written survey. And I suppose a lot of the feedback centered on being listened to, feeling that there was time for them to talk and to tell, their story, and that particularly transpired well in the outreach clinics, because people felt at home. I think they weren't out of their comfort zone, and they were able to identify with the team that were looking after them, and they felt that was really good. I think family members felt that they were being heard as well, because obviously care is strain, and particularly in COVID, if you're looking after someone who has dementia or high care physical needs, it is hard going. And I think a lot of time people just needed to be able to vent that and have the support there that they could go to when they needed it. And I can't remember, there's something else about the question there.
No, just in terms of older people identifying their own needs.
Yeah. And I think that'll come. I suppose it's hard in a pilot service to do that initially, but what we're trying to focus on as a team is obviously the assessment part, but also the intervention part. And I think some of the work we've done with our colleagues in the Aging Well networks, and there's been a load of investment in those posts as well, I suppose, through the ECC funding. And we're looking forward to working with the health promotion teams to promote, healthy aging, and look at community initiatives. We've spoken about falls prevention classes, social prescribing. All those programs are really beneficial, particularly for older people. So we look forward to getting a bit more into that now that we've been streamed.
Great, thanks, Michelle. And finally, Elaine McDonough wants to know, are there any plans to include a mental health nurse on the IOCP team?
Yeah, we have an excellent psychiatry for later life team here in the West that we work with quite closely, and we're looking forward to, now that we've been able to expand our team, that we'll be integrating with them a little bit better, maybe a bit more formally. They probably had an established service before us, so there is a lot of overlap. And again, that's kind of teasing out the various services and who does what, but there's a need for both of us. Our psychiatry colleagues are really excellent at managing, particularly, more advanced dementia, those kind of behavioral symptoms, and we work very closely with them. So I think, that idea of having a link person, be it a nurse, be it another healthcare professional that joins up with these teams, is going to be crucial. And actually, listening to what Sean was saying, and we've seen it already in our outreach clinics, we've patients that see in the diabetes integrated team, and they're also seeing us, and kind of linking up all those services is going to be key. and information sharing and accessing each other's notes so we're not duplicating stuff is 101. Like we need a good ICT infrastructure for that.
Exactly. Great stuff. Thanks very much. Can I come to you, Kathy? Kathy from the Donegal Heart Failure Service. Kathy, lots of congratulations coming in for you from colleagues and others in Donegal, congratulating you on the service. And as Michelle Donnelly says, making a difference to the patient experience. So big pat on the back there for you. Michelle, maybe, Kathy, if you just would talk a little bit, now that your project is being mainstreamed, what do you envisage the future of the service will look like as it becomes more mainstreamed?
Thank you to all those awful congratulations. We're delighted to get it this far and delighted to hear that we will be mainstreamed under the enhanced community care, because we really felt from the beginning that this model and project was written towards the Sláintecare vision. Now, it's still in the early months. We hope that over the next first period, we will expand and develop the service as it is, but really hope with the addition of the new staffing that's identified in the enhanced community care model and a community cardiologist, that we will be able to roll it out throughout the county and make sure that we open it up to other cardiac diagnostics beyond heart failure, that we'd be able to support from a nursing point of view other cardiac conditions and develop cardiac rehab around the county as well. Now, there has to be some further conversation, I think, because some of our funded posts in this project don't completely align with the enhanced community project. So the advanced nurse practitioner post, for example, at CNS in it. So there will be a bit of work to see how that's going to be developed, but we really strongly feel that the extra expertise and experience and decision making the advanced nurse practitioner post and that the chief physiologist post actually has enhanced our project and really meant that we have reduced greatly the number of patients who need to refer into secondary care.
Very good. And Kathy, tell me, have there been any additional or even unexpected outcomes that the project has seen to date? Anything you didn't envisage?
Well, there was a lot of learning along the way and a lot of adjustments, and we talked the whole way through about COVID and how things were adapted. So we did achieve our goal, which was to open up diagnostics and nursing support to GPs that was avoiding going into the hospital waiting list. And because we moved from COVID, as Karen said earlier, to that hub and spoke model where we developed these joint clinics. So it was physiologists and nurse then clinics together in these primary care locations, that not only were we able to take in and reduce to have no waiting list for new access, new patients from GP referrals, but we also were able to follow up patients who were admitted with heart failure in their local area. So that, from a patient perspective, really is the feedback of not having to travel that long distance. As Karen said, over 100 kilometres per visit, a round trip is no mean feat. Donegal's a big county. So that was a huge gain that we didn't really think about when we were planning it. And the other one was our waiting list, of course, for the hospital recall waiting list. We are now seeing patients that haven't been seen in 3-4 years in the heart failure clinic, but seeing them in these new community clinics. And there's new therapies that have come out since they were last seen that we're now making sure that they're getting their evidence-based treatment and being reevaluated.
Great. And a question has just come in from Annette O'Connell, and she wonders, how will the current integrated heart failure service work with the planned cardiovascular integrated hubs? Bit of a technical one there for you.
And that's, I suppose, that is part of the conversation. So we're specifically looking at heart failure from a service. Enhanced community care is really cardiovascular. So it is envisaged that there will be atrial fibrillation, for example, ischemic heart disease, hypertensive heart disease, and heart failure. So we don't know if they are going to be clinical nurse specialists in each clinical network hub managing all those conditions, but that will evolve over time. I would think that it might be the case rather than having individual specialties around the country.
Yeah, sounds like that's the way forward. Thank you very much, Kathy. Can I come to Mairead? Mairead, you mentioned your project really only commenced in March of this year. What were the main challenges that you faced, starting as you were, a number of months beyond what you had hoped your start would be?
Yes, I suppose one of our first challenges was actually getting staff into the posts. So eventually we actually managed to fill all 10 posts across the 2 sites in January and February. But that was also then, as we are all aware, a very challenging time for, I suppose, all of us, the 3rd wave of COVID. So definitely our main challenges were, what we found as we were starting to get our services up and running was accommodation. So initially all our services were moved online, but we were kind of planning for resuming face-to-face. We were aware the vaccination program was accelerating, and a lot of our patients, some of them were able to come on virtually, but a lot of our patients weren't able to engage virtually. So accommodation was, I suppose, very challenging, more so with COVID, all the extra space that's now required. So actually, it was just fantastic to work with Sláintecare and Pobble, because they were very flexible with making slight adjustments to our budget, actually. So we were traveling less because of COVID and everything was virtually. So therefore, the savings from the traveling we're able to divert to use actually to rent out. So one of the services, particularly, is pulmonary rehabilitation, which is an exercise class, and it needs quite a large room, and even larger now for the extra spacing. So we ended up having to rent actually a space in a gym hall in Longford. And it was just great to have the fund, just to divert funds, I suppose. So it was great to get support and the flexibility from Sláintecare to do that. And the feedback has been fantastic, again, from patients, to be back face to face. It's immense. And I suppose when it comes to pulmonary rehabilitation, our outputs per month was to do 8 classes a month. And across the 2 sites for April, we were delivering 35 classes, so exceeding our outputs immensely. Another challenge was around GP engagement. Again, GPs were battling the 3rd wave, and then they were very overwhelmed with the significant vaccination program. But we were lucky in both sites that we had GPs on our local implementation groups, and they invited us along to education sessions for the GPs in the evening times on Zoom. So it was via that we got to engage with the GPs and inform them of our service. And also as well, at the same time, we actually got set up on HealthLink. And this was the advice from the GP lead on the chronic disease program, Mark O'Kelly. He said it's just the best way to interact with GPs. So from the horse's mouth, essentially, we were... Yeah. But with that, once we got up on HealthLink and after the engagement on Zoom, the referrals have just, we're being floored with referrals, and we haven't, I suppose, as we're a newer project, we've only started our engagement with the GPs, but it's again been fantastic. And I suppose just another thing just to note as well was, again, I suppose, as mentioned in Donegal, our 2 sites, one is Bray, which is quite, urban, and then the other side is Longford, Westmeath, which is quite rural. But the development of the spirometry service there, the diagnostics to patients in Longford is like that. They have a very long round trip to Mullingar normally. So, so 86% of the 82 patients seen in Longford through April, May, and June didn't have to go to the hospital. So just fantastic results.
Great.
Yeah.
Great. Thanks, Mairead. And you've answered a question that came in about the GP buy-in and how did you do it. So well done in skipping to that one. Thank you so much. Lorna, can I come to yourself now around the diabetes end-to-end project? A question has come in actually from Sloane Harper, who's the chair of IFIC, the integrated forum in Ireland. And it's a question for Professor Janine, but I'm sure you would be able to answer it for us. She wonders, could GP involvement be encouraged through a leadership role on the future CHNs, or maybe supporting their input to case study discussions at virtual consultations? So she's trying to, thinking of ways in which GP engagement. Have you some response perhaps to that?
Yeah, Prof. Janine didn't mention, but we have had excellent engagement with the lead GPs on the lead network GPs. These are new appointments. And these GPs have been sitting on our local implementation teams and supporting the clinicians and getting the services up and running. So have been, this new dedicated resource to the community health networks has definitely benefited us in setting up the service. In terms of case discussions, we're feeling our way, and this new MDT fortnightly review was a new development. So we just haven't managed to get GPs to come onto that on a Thursday afternoon. But I think with the new specialist interest, GP posts with a specialist interest in diabetes, it's definitely something that we will be able to explore because there'll be dedicated time to support these MDT reviews. So yeah, absolutely. It's all, you know, there's lots of potential to explore those roles. Another role as well would be the complex case coordinator role, which is coming along with the new networks. And I think that type of role, and I see a question there about BD insulin and who will administer the BD insulin in these complex patients. And we've definitely come across this. This is a huge issue. There's a massive gap there at the moment because it's not the public health nurse's role and it's not the CNS's role. And we've been trying to tap into resources like the CIT, Westdoc, GPs out of our service to try and manage these complex cases. But hopefully with the new community health networks and the complex case coordinators, we'll be able to find and navigate our way through these complex issues.
Great stuff. Thank you so much. Michelle, back to you, another question. What can newer programs learn from established programs like the ICPOP? New programs, how can they learn from these more established programs?
I think, I mean, one of the key learnings for us when we kind of started, I mean, obviously we were aligning ourselves with the national program, the integrated care, and they had a 10-step framework. And I think, you know, a lot of people have mentioned governance and getting your kind of ducks in a row in terms of the movers and shakers within the community, and just getting to know, as particularly I come from the acute side, and this is us branching into the community. So I think getting to know your colleagues on the ground, and you know, getting to know who does what and where it's happening on the ground, because I think, no offense to national policies, but sometimes they're a bit removed from how things really are.
Yeah.
And I think that's one of the big learnings for us as a team. You know, we just had to get out there, meet people, and I'm sure everyone has experienced this within the projects, because, you know, there's nothing like, you know, well, I know that person, or I know how to get at, you know, what you need. And I think, you know, our primary care colleagues have been really instrumental in that. And I think the other things that I think, you know, and maybe Sláintecare and the ECC program can take some of this is around recruitment and ease of recruitment and filling posts and backfills of backfills, because, you know, the scale of recruitment at the moment, but I don't know if the HR processes are kind of, you know, more than the ICT, like they're lagging a little bit behind, and that can be difficult when you're chomping at the bit to get a team going, but you know, you're encountering all that. Maybe I'm speaking out of turn, but I think you know, it's certainly something we've probably all encountered.
Exactly. And I think, to be fair, it was something that Pat Healy mentioned at the top of the webinar, that they acknowledge this is one of the big challenges for really getting the wheels under this, is to get the people in post as quickly as possible. Look, I'm afraid we've run out of time again. Thank you all so much to our panelists. Thanks to each of the guests who are here today, all of the panelists who featured in the videos, and well done to all of those great project work as it continues. Today's emphasis on enhanced community care, I think it's a message of hope, and it really concretizes what Sláintecare is about. And it shows, I think, how the many innovative ways that people are working are really making a change and are making the health and care services so better for all of us. I want to thank everyone. I want to thank the team here who helped produce the session: Rosaline Harlan, Muriel Farrell, Kira Eustace, Lindsay Dre, Ingrid Doyle, Erica Kinsler, Suzanne Lynch, and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, and do send us your feedback. We do like getting it. The questions we didn't get to answer or which weren't answered will be posted to you in the coming days, and you can send those to us. So from me, Gráinne Healy, and all of my colleagues, continue to stay safe, wash your hands, and hold firm, and we'll see you next time. Thank you very much.